Hello, everyone. Today I'll be talking about functional tremor. So tremor is a very common symptom like we see often in clinic. During my rotation here, I saw tremors from patients with Parkinson's disease and essential tremor. And I found functional tremor particularly interesting because it can has many different kinds of types, and they look like other kind of tremors, making it very difficult to diagnose. And I think it's very important to recognize functional tremor because in that way we can give the patients the care that they need. So in this presentation, I will talk about first tremor, and then I will focus on functional tremor with an emphasis on diagnosis. So tremor is an involuntary, rhythmic, and oscillatory movement. In other words, it's shaking and trembling without conscious control. And it can involve one or several different body parts. So hands are the most commonly affected body parts. Functional tremor can also affect arms, legs, head, vocal cords, and torso. When we describe a tremor, we need to pay attention to the frequency, which means how fast the shaking is, and amplitude, like how big the movements are, and the rhythmicity, how regular the shaking is. A functional tremor is a subtype of functional neurological disorder. It is not due to structural brain damage. For patients with functional tremor, the MRI of the brains are mostly normal. It is involuntary, but sometimes the movement can be modified. Functional tremor is often triggered by stress, trauma, or psychological factors. However, not all patients with functional tremor have psychological or psychiatric diseases. And subsequently, psychogenic tremor was replaced by a more neutral term, like functional tremor. For the epidemiology, functional tremor is the most common functional movement disorder. It affects patients with all ages. The peak onset is between 30 to 50 years old. It's more commonly seen in females, and depending on different studies, the ratio of affected females versus males is around 2 to 7 versus 1. And in males, the onset of functional tremor is usually late in their life. It often coexists with other functional neurological disorder or psychiatric illness. It's very important to make a correct diagnosis, and it's usually based on history, clinical examination, and neurophysiological examination. So first, history. Functional tremor often starts abruptly. The patients sometimes they can tell you the exact date and circumstances when the tremor started. And there are also sometimes risk factors or precipitating events, such as physical injuries, surgeries, infections. And functional tremor, it varies in frequency, amplitude, and sometimes it can change from one body part to another body part. Patients usually have a history of unresponsiveness to medications, but they can respond to placebos. And psychotherapy sometimes can help with remission of the tremor. There are also sometimes non-motor symptoms, especially chronic pain, anxiety, and fatigue. Clinical examination is particularly important, and there are some universal features of functional tremor. The first is frequency variability. This means that the tremor frequency changes during examination and interviewing with the patient. The second is entrainment of fold suppressibility. So entrainment means that the tremor frequency can sometimes changes to match the movement of another body part performing a repetitive or voluntary task. For example, a patient with tremor in the left hand, if the patient is asked to tap with the right hand, the tremor in the left hand can change its frequency to match the tapping rhythm of the right hand.
Oops, sorry, yeah.
The third is distractibility. So it means that the tremor amplitude can attenuate with the distraction of the attention from another body part. The tonic coactivation is a simultaneous and continuous muscle contraction of the agonist and antagonist. It can lead to stiffness and ballistic suppression. So ballistic movement is a rapid and forceful movement, such as throwing a ball. So when the patient with tremor and when they do such movement with the hand without tremor, sometimes the tremor in the other body part can go away briefly. And there are also some optional features which may not present in every patient with functional tremor. The first is that the tremor amplitude, it increases with weight loading on the parts of the body which tremors. And the second is Raynaud sign. In this, this means like when the examiner is trying to stop the tremor of a body part, the tremor will spread to the other body parts. And there are also some other functional signs of phenotypes. So here is a video of a patient during a clinical examination. And let's see this video together.
Yeah.
Okay, so can you tell me like which feature this video is showing? Let's see it together. So we can see that the tremor amplitude in this hand is decreased when the patient is doing repetitive movements of the other hand. So the same happens to this hand. So this is an example of distractibility by using motor task. Distractibility can also be performed by asking the patient to do a mental task. For example, in this video, so the patient is asked to count months backwards, and she has tremors in the right limb. And we can see the amplitude and the direction of the tremor changes, like while she is counting month. And sometimes we can see the pulse of the tremor. And neurophysiological examination is also very important to help us to diagnose functional tremor. And we use surface electromyography, SEMG, and accelerometry. So for the surface EMG, the electrodes are placed on the surface of the muscles that's involved in the tremor. And normally we include both agonist and antagonist. And this one here is an accelerometer, helps with accelerometry. And it is connected to a computer for better characterization of the tremor movement. And the picture below here is showing weight loading. Here is a result of neurophysiological examination by using SEMG and accelerometry. Right, RT here means right, so there's tremor in the right limb. The upper trace is accelerometry showing the tremor movement. And here F means flexor and E means extensor. So there are two muscle groups. And we can see the muscle extractions during the tremor. And when the patient is asked to tap with the left finger, so here shows the left finger movement by using accelerometry. So the patient tap the finger at a certain frequency, and we can see the muscle extractions changes in the right side, and the muscle burst and the tremor movement. They are trying to the frequency changes to match the one with the left side. That is the tapping frequency. And the underlying causes of functional tremor is still not understood. Abnormal connectivity between limbic and motor regions have been found by some studies. It is believed to be a combination of altered emotional processing, abnormal beliefs and expectations, and excessive attentional focus, which lead to impaired sense of agency. In other words, the patients, they don't feel like they are doing the actions. Amygdala hyperactivation was recently suggested as a biomarker. And stress and trauma, they also play an important role in functional tremor. It is important to note that functional tremor is real. Recent functional MRI studies found decreased activation of the temporoparietal junction region when they compare functional tremor and voluntarily mimicked tremor. The treatment includes pharmacologic therapies and non-pharmacologic therapies. Studies have found antidepressant treatment, botulinum toxin, chemodenervation, and placebo. They can help amelioration of the tremors in some patients. And medications that are not indicated, such as levodopa, should be weaned off. Non-pharmacological therapies include physiotherapy, cognitive behavioral therapy, repetitive transcranial magnetic stimulation, and biofeedback. For example, during biofeedback, so the patient is looking at a monitor showing his hand movement, and the patients, they will try to keep the line flat. So in that case, they will eventually try to control their tremor movement. As for the prognosis, 60 to 70% of patients, they can show some improvements with appropriate care, and early diagnosis can lead to better outcomes. However, prognosis can be poor if the patient has tremor for a long time, or they have some other medical illness, or they are not believed by their family members, friends, doctors, or other people. So the take-home message here is that functional tremor is common and it's real. And it's very important for us to make a correct diagnosis based on history, clinical examination, and neurophysiological examination. The key features include distractibility, variability, and entrainment. A multidisciplinary treatment sometimes can offer a better outcome. And here are the references used in this presentation. Thank you for your attention.
Okay. Can you